So thank you all for joining us this evening. We're just going to give a minute or two to let everyone enter before we officially start. So while we're waiting, please will you just check that your microphone is muted, and we're going to ask you to stay on mute during our panelists' initial conversation. We will have a chance later on for some Q&A and audience interaction, but until then, please do keep yourself muted. Okay, a lot of people are already in the room. So let me start off by saying a very, very warm welcome to this evening's session. For those of you who don't know me, my name is Aviva Dorch, and I'm the director of Jewish Renaissance, which is the UK's Jewish Arts and Cultural Quarterly. We've been running a series in association with the Lions Learning Project, a pluralistic Jewish learning organisation over the last few weeks. And the theme of the series has been medical ethics, Jewish medical ethics. We've looked at issues from new advances in scientific technology and bioengineering, through to the moment of conception, with both questions around genetic screening and new reproductive technology. And last week, we were looking at the issues around organ donation and what new advances, particularly with animal transplants, might mean both physically, but also ethically. But tonight, we really wanted to do something different, because medical and health isn't just about the body. It is very much about the body, but health is also about the mind. And I think we are all very, very aware that over the past 2 years, things have been particularly difficult for people mentally as well as physically, as we've all dealt with what the pandemic has brought us. So we thought it was really important to have a discussion about mental health and well-being, but within a Jewish environment and a Jewish framework. And I don't particularly mean a legal framework, I mean a community framework and a relational framework. I'll come on to that in a moment. I do want to say, in order to do these kinds of important conversations, I think we have to be sensitive and careful. So while we've been dealing with difficult subjects all through our series, tonight I do want to say to people, those of you who are speaking, those of you who are listening, we are going to be handling sensitive questions. I'm going to ask you therefore to keep the trust in the room. We're going to talk about things hopefully openly and honestly, but also with care and sensitivity. We're going to try and warn you if there is anything difficult coming up, but otherwise I'm going to ask you as our audience to just think carefully about what it is you're hearing and what it is you'd like to ask. And later on in the evening, we will definitely be bringing your voices into the conversation. So if you are thinking that there are topics you would like to cover, please put a note in the chat and we'll come to those later on in the evening. But for the first part of the evening, I'm not going to bring in the audience, but I'm going to bring in 4 voices on a wonderful panel. I'm really surprised because talking to them in advance, I find none of them know each other, have ever met or have ever been on a panel together. So I'm hoping there are going to be lots of creative sparks flying as we have engaged in some new conversations. All 4 of our panelists come from different perspectives and different points of view. We have Howard Cooper, who is a rabbi and a psychoanalytic psychotherapist. I've no idea how he manages to balance not one serious career, but two, because he's an active minister serving at Finchley Reform Synagogue, and he's also a therapist and training analyst in Barnet. And on top of all that, both ministering and listening, he's also a writer whose publications include Soul Searching, Studies in Judaism and Psychotherapy. Next, we have Louise Morganstein, who is a consultant child and adolescent psychiatrist with particular clinical expertise in autism, ADHD, and depression. She's the lead psychiatrist for the Brent Child and Adolescent Mental Health Service at the Central and North West London NHS Foundation Trust. And she's also on the clinical governance and advisory group of JAMI, the Jewish Association for the Mentally Ill. David Gilbert, our third panelist, is a patient advocate. A former mental health service user, he's the author of The Patient Revolution, How We Can Heal Healthcare, and he's director of In Health Associates, which is an organisation that supports patients, service users, carers and citizens to work with professionals as equal partners for change. He's also a visiting lecturer at the University of Hertfordshire and poet in residence at the Bethlehem Gallery. And last, but very much not least, we have Susie Orbach. Susie barely needs an introduction, I'm sure, but I'm going to give her one anyway. She's a therapist, a social critic, and a writer. Alongside her clinical practice, she lectures and broadcasts worldwide, and she's been visiting professor at the London School of Economics and the New School for Social Research in New York. She's the author of numerous books tackling subjects such as gender, food, body image, and how it affects our sense of self. And her 2018 book, In Therapy, The Unfolding Story, based on her BBC Radio 4 series of the same name, explores the therapeutic process. So we're really, really delighted to have Howard, Louise, David and Susie with us. And we're going to start in that order. And we're going to start by going round our panel twice with questions based on Rabbi Hillel's famous saying. So as you've already heard, our panelists come from very different parts of the mental health, the mental well-being community, and we're really looking forward to them not just bringing different perspectives, but exploring different areas. But the one thing that I think links all of us is that negotiation and conversation between what it means to be an individual and to look at the world as an individual, and also to be part of society. So Hillel's famous saying that is part of the ethics of the fathers is, if I'm not for myself, who will be for me? But if I'm only for myself, what am I? And if not now, when? So we'll do the if not now, when a bit later, but let's start off with that phrase and ask Rabbi Howard Cooper to kick us off in terms of what he sees it meaning for today. Over to you, Howard.
Thank you very much, Aviva. I'm going to speak about wellness, first of all, because there's a question which comes to my mind when I hear this phrase about well-being, which we hear all around us all the time. What does it mean, though, for a person to be well, to be in good health? You know, someone comes up to us and says, how are you? How are you feeling today? And if we answer the way I normally do, which is a kind of social politeness, oh, I'm well, thank you. I mean, what does it mean? What does it mean to be well? That's where I'm starting. I think, though, that wellness clearly is an aspect of our selfhood. If we recognize ourselves as being minds and bodies, a unique amalgam of emotional, physical, mental and spiritual aspects of personhood, all of those together, I suppose, combine to give us a sense of ourself, as well as having a personal history, which binds it all together, a story about our own lives. This is who we are. But when we see how complex those different components are, emotional, physical, mental, spiritual, I think we could recognize how precarious wellness can be and how subjective it is, how much it depends on different aspects of our psyche-soma continuum functioning together in harmony. We can't take any of that for granted. Our minds and bodies, we know, both our minds and bodies, are fragile, vulnerable. They can and do let us down. So being well is more akin, in my mind, almost to a state of grace than a conscious achievement. I know people think that they can work towards being well, and to a certain extent, of course, we can. But there are questions in my mind about how successfully anyone can achieve wellness. And I think our sense of ourselves as being well or not is impacted not only by what goes on within our own body and our own mind. I mean, this may be an obvious point, but I'm just laying out the territory. Our sense of being well is not only impacted by what goes on within our own self and selfhood, but we all live in a societal context. And human well-being, we know, is influenced by many factors which are external to the self. I can make a small list: poverty, racism, sexism, prejudice, discrimination, campaigns of disinformation, the pressures of consumer capitalism. This is the context we live in and try to be well in. And all of that has an impact on our well-being. So we can work as much as we want in our own little bubble trying to be well, but we've got all of that collective pressure around us in which we are completely rooted. So it's a complex question, this, about wellness. So I'm starting with the recognition, not only that we are innately vulnerable as human beings, with bodies and minds that can fail us, but we are fundamentally social and relational beings. We're bound up in a nexus of interrelationships with others who can impact our individual well-being for good or for bad. Societies, communities, the planet itself needs care and attention in order for it to function well, and in order for individual human well-being to flourish. I think we need to think about this question of wellness, in other words, in a holistic way. We are part of this nexus of relationships, society, community, and the planet. And the work that's involved in getting all of that to work for our wellness in a non-utilitarian way of getting it to work for our wellness is a really complex societal job. So that's the first point. The second point is much shorter that I want to make. It's about societal isolation. I think it's one of the key underlying factors in our emotional well-being. And there I think that the breakdown of community cohesion, particularly in large cities, is very much something that is problematic for our well-being. And here I would put in a word for the fact that the Jewish community can offer, in different ways, people a sense of belonging, a sense of community. And so I think we need to be, first of all, grateful for the opportunities that that presents and be able to really capitalize on them. But I think I'll stop there, and then I'll let other people come in and with their own perspectives on this. I've tried to lay out a larger background in which we're going to be talking.
Brilliant. Thank you so much, Rabbi Cooper. So I think if I'm getting your 2 points correctly, one is about context being everything, the society and the political structures of society all bear down on us in different ways, and also the problems of isolationism, and how does a community deal with that when communities seem to be breaking down. So really interesting, almost provocations to get us going, and I really appreciate that. Thank you. So I'm going to bring in Louise next, who is a psychiatrist and someone who particularly works with young people. I'll be interested to hear.
I'm going to move us from wellness to think a little bit more about illness. And mental illness can often be an intensely personal illness. It's an illness that is often not seen and often poorly misunderstood. But when we think about recovery, and I guess we might think at a later point about what does recovery mean, or, you know, who is recovery for, but getting better in some way from mental illness is often reliant on a community being both responsive, but also taking responsibility for the context of mental illness and the fact that mental illness exists within a community. And when I was sort of thinking about what I was going to say, I was thinking very much about the quote that's often attributed to Margaret Mead as an anthropologist about what was the first object that made you think about civilization. And she talks about that being a healed femur bone. So where there'd been a fracture of a hip bone, sort of upper leg bone, and that there'd been an advantage, that possibility that somebody could be cared for and allowed to heal. And I think within the Jewish community, we do that caring really well. But it made me wonder about, is there a need? Why do we need a specific Jewish mental health response? And the research on this is relatively limited in terms of what do Jewish people get more mentally unwell than other people? The research seems to suggest that Jews don't get more mentally unwell than any other part of the population. And that's when you're looking at Jews as a sort of race or religion, but also if you look at Israel as a country, there's no worse mental health in Israel than any other place in the world. There is a slight difference in the expression of mental illness. So we see that, for example, with OCD, there's a slight difference in the symptoms that can be attributed to those with more religious beliefs, in terms of, we see OCD being about kashrut or about cleanliness, but it's still fundamentally the same illness. So why do we need a Jewish mental health response? And I think that comes down to that community sense, that recovery being part of being in a context of other people. And that's where I think JAMI as a charity can kind of really come in and offer both that individual response. So JAMI works with individuals who are unwell with their carers and their family, but it's also about empowering the whole community and educating the whole community to think about mental illness, to understand mental illness in a different way. And I guess I just wanted, as a child mental health practitioner, I wanted to also just sort of briefly think about children and young people. And when we talk about community, it's very easy to think about a geographic community or a religious community. And I think with children and young people, their sense of community is so much broader. And that's partly because of technology, but it's much more than that we know that for children and young people, how they act when they're on their own can be fundamentally different to how they act when they're part of a peer group. They're much more likely to take risks when they're part of a peer group than they are when they're on their own. And so that sense of other, that sense of context of where you belong, identity, who's around you, is just so important for children and young people, but it doesn't go away as you get older. I think, again, I'm going to leave it there and hand on.
Fantastic. Thank you so much. And again, raising lots and lots of starting points for the conversation that I'm hoping our audience are going to join in later on. Not just that question about kind of what is or should be, or should even should there be a specific Jewish response, but I found really interesting what you were saying about the level of mental illness, because I think we think about the Jewish community in terms of mental health, particularly in terms of inherited trauma, so much because of the second and third generation impact of the Holocaust, because the Jewish community is a very studied one. So for example, in fields like epigenetics, I was just talking about inherited trauma, because we have been so studied, I think there tends to be a focus. And I find it very interesting what you're telling us is that actually we are no different from the general population. So if we are no different, should we be looking at universal responses rather than specific ones? So I think that's one really important thing to raise. And also what you've just said to us about technology, and I think it's really important for children and young people, but also, as we've all found during the pandemic, is that restructuring of the idea of community something going forward we really need to take account of. So thank you so much, Louise. I'm going to bring David into the conversation now. And just to tell everyone, David's going to he's coming as a patient advocate, but also with his own experiences of healthcare. So he's going to answer this in a very personal way, including covering some very difficult experiences that happened to him. So just to warn you all that there might be conversations and mentions of, for example, suicide. And if this is worrying for you, kind of think about whether you want to participate or listen to his speech. But I'm going to hand over now to David.
Thank you very much. I'm going to talk about power, and I'm going to talk about how the healthcare system is broken and how it largely ignores the needs of what actually matters to people who use it. And that is because patients don't have any power in the system. And I want to put that in the context of a breakdown I had at the age of 25, where my relationship to self was broken. My relationship to others, my friends and family, was broken. My mother, a Kindertransport refugee, couldn't bear to see me in a psychiatric hospital. And my relationship to society was broken. Who I was not who I would be. My identity, my purpose, my meaning had all been put on the shelf. So I was halfway through what people laughingly call my patient journey, my patient pathway, as if it's a walk in the meadow rather than hanger lane gyratory system at rush hour. And one of about a dozen junior doctors who came to see me, no continuity of care, nothing to do on the ward, the food was rubbish, came to my bay. And even then I knew his behavior was slightly odder than mine, and continued to check the curtain rail to see. I didn't know. I asked him what he was doing, and he gave me oh, you're there, okay. I'm just checking to see, David, that you're not going to do anything stupid, and walk down. So for those who don't know, that was checking to see that it wasn't a ligature point. And this is a long time ago, but still. Fast forward 10 or 15 years, and I was head of patients and public. I was at the first inspectorate, the Commission for Health Improvement, what is now the CQC. And we were inspecting to look at safety standards on psychiatric wards. And the standard we were inspecting against was to reduce 100% to reduce to zero the number of inpatient psychiatric suicides by, guess how, removing all non-collapsible curtain rails. And I thought of my friend Leslie, who'd been paralyzed from the neck downwards and then discharged to residential home and choked to death unsupervised. I thought of Larry, who deliberately drowned himself in a local reservoir near the psychiatric unit just up the road in Barnet. And I thought of Steve, who absconded, the word we use for mental health service users, as if they're criminals, who did the deed in his caravan. And I thought of how we hit the target and missed the point. And the fact is that if that doctor had come in and asked a different question, what makes safe for you, I would have talked about relationships. So the very notion of what safe means is contested. That for service users, for patients, for family, it's often nested in those relational issues we've talked about already. But for psychiatric staff, it's largely about containment and isolation. Now, why doesn't that change? We'll talk about that later, but part of my career, in fact, a general thrust of my career, is ensuring that patients, service users, carers have more power in the system. So we'll talk about that later, because we don't focus on what matters because patients don't have power, is my thesis.
Gosh, very, very interesting. And thank you for sharing such difficult material with us. But I thought that was so perceptive about hitting the target, but missing the point. And the point you're making seems to be about power, about autonomy, about relations, but also about listening and care, that it's really about care and compassion. So we'll again take these things on, but I very much appreciate you sharing that. Thank you. I think that's a really good moment to bring in Dr. Susie Orbach. Susie.
Oh, thank you, everybody. I've got different things to say to all of you, but I think I suppose what I was thinking when everybody spoke was nobody goes into this field unless they're in difficulty. And part of what Dave's talking about, I think, or what Howard's talking about when we say, how are you? And people don't say, actually, not so good today, is because we don't have we don't educate our kids to be emotionally literate and to be able to tolerate emotional complexity. And emotional complexity doesn't mean we all feel the same way. It means we feel many things the same way, which relates to young people particularly. And we also need to differentiate, which is what Aviva was talking about. So I was thinking that part of the difficulty is that those mental health establishments, and for the kind that Dave is talking about, but the ordinary medical establishments through which we pass, the workers in them are often not listened to at all. Neither are they given the skills to talk. There's a notion of supervision, and there used to be bailing groups, but there's none of that really anymore. It is, and the amount of upset and sorrow that is in our culture, which lands on teachers and mental health workers and doctors, is absolutely enormous and leads to really kind of perverse functioning within the health system. In whether it's the envy of the nurses who would like to be a little bit anorectic themselves and therefore have brutalizing practices towards their patients, or the doctor who can't bear to hear because she or he or they have not been heard. These are very fundamental problems in the training of our teachers and our doctors and all of those that we interact with, right? It used to actually, there used to be a space within social work, within medicine for listening and for hearing. And I think that's really diminished with the target culture, and it's diminished in the university structure. It's just diminished all over the show. So that's one thing I wanted to say. And I think as a therapist, what I'm always interested in, I mean, I'm interested in lots of things because you can't do this job without being really curious about almost everything and learning everything, whether it's whatever somebody does on their job or how they do or don't make love or talk to the milkman or whatever is I'm actually interested, and I'm sure this comes from coming from a secular Jewish background in which there were always people in the house and there were always people staying and they were always in trouble, whether they were refugees or they were somebody's 17th aunt twice removed, is that what I really learned was about community and about friendship. And what I see in my practice is, or what I'm very interested in, despite being fascinated by the tiny little ways in which we all make sense of things, I'm also interested in, do you have friends? Do you have somebody that you hang out with? How alienated are you in your relationships? Who matters to you? And I guess that's the theme that you introduced by your opening remark, Aviva. And it is very much, it's Jewish, Latin, Italian, Black, Asian experience. I mean, it really matters to me that, I'm sure I can go to other cultures as well, but it's very, very much the piece that I feel connected to in terms of what it means to be a Jew. So I think I'll stop there for the moment.
Thank you. Well, I love that focus on warmth and friendship and relationship, because it hasn't gone unnoticed by our participants that we're doing this panel on Valentine's Day. And I was reading someone earlier, it was an op-ed piece, and I'm not even sure whether I agree with the first part of it, but the basic line of it was, sex is easy, relationships are hard. And it was a kind of encouragement that, and I was like, well, I'm not sure sex is so easy, correct. But I think the bit about relationships being hard or being work, and that notion of relationships being obviously more than just love, right? Romantic relationships, but friendships, there is work that goes into them. And I think maybe one thing you seem to be saying about our culture and other cultures is that's work we know how to do, or we're used to doing, or maybe we don't even see it as work, we see it as practice. But I can see other people actually on the panel shaking their heads and don't agree with me. So I'm going to bring in a minute David to comment on that. Before I do though, I just want to open this to the audience, because we are going to go around the panel one more time. But as I keep saying, it's a conversation, and our panelists actually are people who are used to listen. So please do let us know in the chat if you would like to make a comment or have a question, and we will come to all of you a little bit later on. But anyway, let me go to David, who was disagreeing with me. And before I do, I will say there was a second part to Hillel's quote, which is, if not now, when? So when? We're in beginning of 2022, we are in the middle of a pandemic. We are at a time where, as Susie is suggesting, the systems are broken. So as well as responding to anything anyone else has said, I guess my question to you all is, so what next? If you could change one thing, if you could make something happen, what would it be? What do you think we need to do now in this moment? Okay. But let me go back to David and bring you back into our conversation.
I wish I hadn't shaken my head, because it's totally thrown me from what I actually planned to say. But all I would do is throw out a question, is can we assume that the Jewish community is good at dealing with mental health problems because of its emphasis on community? And I think for me, my childhood was so utterly different, surrounded in an emotional repression, not wanting to talk about the Shoah or the Holocaust, my mum not ever wanting to talk German, that I had a very different experience around community. So that it's just a question. But what I'd really like to just pick up on is Susie's point about staff. Part of my work, when I first saw that patients didn't have power, and saw that the ways that the system listened to patients are not fit for purpose, whether they're focus groups or surveys or whatever, was a realization that patients really wanted to help. and that people came in, but there were very few opportunities to help, to sit around the table and come up with solutions. So all my work now is about providing opportunities for patients and service users as leaders, as improvement partners on committees, and finding solutions with staff who are desperate to try and reconnect with their own humanity. So I think there is a possibility of caricaturing my first angry story with, like, here's one of these radical survivor user voices. But actually my work has taken me in a very, very different direction. I was the first patient director in this country. That's an equivalent of an executive level post. And just yesterday, I was on an interview panel with a major mental health trust where they're appointing the first 2 lived experience directors alongside clinical and managing directors. So all my work is around how can we all work together, staff and patients, staff and service users. And so I think it's because of the lack of systemic opportunities for people to have their voices heard that we need patients at every level of the organization. And that is a very, very, very slowly emerging social movement. And you'll hear more about it, I promise, in the next year or 2.
Brilliant, thank you. Well, I think I'm hoping and looking forward to that social movement. And I think we'll go to Louise in a second, because you are talking about this from the patient advocate perspective. But Louise is obviously coming at it from a member of that system, which we're all talking about within an NHS Foundation Trust. Just want to pick up on one more thing David said though, and raise that too, because you started at the beginning by saying the Jewish community did not know how to handle the post-Shoah experience, and therefore community is not necessarily the solution. I would also ask, and both Louise and Howard are coming from a Jewish communal perspective to an extent, does the Jewish community also add pressure and adds complications? Because you can have communities that make assumptions, you can have issues with people who think they have to fit in or be a certain way. Is it really as simple as community protects and saves? So let's go to Louise first and then to Howard. Louise.
Thank you. I guess before thinking about kind of what needs to change, I wanted to just also respond a bit to Susie's comments around perhaps the lack of reflective practice within current NHS teams. And I think if there have been some good things to have come out of the pandemic, and I guess the fact that we're all sat here on Zoom and people can be all over the world and logging in is one of those things. I think one of the other things, and it comes from a dark place, is that actually physical health practitioners, I think, are now increasingly aware of the moral burden that mental health practitioners have been carrying. And people talk about the sort of the concept of moral injury. And I think that we've well known within mental health teams that we need to talk to each other, and we need to support each other, and we need to challenge each other, because otherwise bad practice can come in on an unconscious level. And I think that hasn't been replicated in physical health services. And COVID and the impact of that isolation and that loss of community, loss of relationships, that the doctors and nurses on intensive care units were the relationships for the people when there were no visitors, has, I think, left those health teams understanding in a different way what it can feel like to carry that weighty burden of someone else's distress, and therefore the importance of that caring for each other. And so I think things are not as bad as, well, certainly within child mental health teams, we have monthly reflective practice, and we absolutely try and challenge each other, but I think in other services it may well not be the same. But I think that might improve as a result of COVID and the experiences that people have had. I'm going to switch to answer the question now. The obvious thing is obviously to talk about resources, and I'm not going to do that because I think it's just so obvious. Mental health is underfunded, and even when funding comes in, it comes in a slightly crazy way that means that actually we really struggle to spend the money that we get, or we can't find people who are appropriately qualified to come up, to fill positions, etc. But my personal interest is actually in infant mental health, and I'm going to say that I would really like the shift to be at the same time as improving current services to look at prevention and optimization of well-being and relationships. And I think upskilling parents to really be the best version of parents that they can be, to get those early relationships right, won't prevent mental health problems in the future. That's not going to be possible, partly because mental illness will always be a spectrum. So if we think about a normal distribution of happiness, even if we shifted that normal distribution so that people who were at one end were less unhappy than people were previously, there will still be a spectrum of emotional feelings. But if we can get those relationships right, we've got evidence, as Aviva was saying earlier, that it changes how genes are expressed. So when we look at epigenetics, relationships mean that genes are expressed or not expressed in a different way. So we can actually change not only how someone sees the world, how they trust the world, how they trust in other people, but we can change the very makeup of individuals. So I'm going to urge that the important investment is in the really, really early years, and in that relationship between caregivers, parents, and their infants.
Fantastic, thank you. So resources, but we all know that, but then go for the early years. I will say there is someone in the audience tonight, I noticed Judith Horowitz, who might have things to say about that, because she's the founder of Apples and Honey Nightingale, which is the first nursery within a care home in the UK. And she's been advocating for that kind of intergenerational work as well as early years work, I think you're beginning to talk about, which is possibly an exciting innovation. Let's take it to Howard next. Thanks so much, Louise. Howard, over to you.
Sorry, that's 2 years on Zoom and I still don't get it right to unmute myself. There's a couple of things which have come to mind listening to my colleagues here. The first is, it's so interesting listening to when Louise talked, and Aviva, in a way you repeated it, you said, well, of course, it's about resources. And, we don't even need to talk about that because it's obvious. And Susie said, almost en passant, something about the target culture, which completely affects how the systemic work of NHS staff work. Now, these are just asides, and we say, of course, but I don't see how we can have a really informed conversation about these questions unless we see how completely political is the context in which over the last 12 years there have been systemic attacks on collective well-being. This is not just a natural process that's unfolded as part of modernity. There's been an ideological battle in play, and it's absolutely not over, between fundamentally different ways of conceiving human well-being. And we're in the middle of that, and it is entirely political. But we're all affected on a personal, individual level in our own context. So I just want to make that point, that this is through and through political, as well as personal. Something completely different. I wanted to just address what David said. I mean, clearly, David, if I understood you right, and if I heard it properly, your particular experience came, this is an issue about Shoah and intergenerational trauma and the Jewish community's response to that. if you grew up in an individual family where the trauma of what people had been through was not spoken about, was repressed, this is obviously going to have big consequences, or is likely to have very big consequences. And that's really sad and unfortunate, and almost exists as a phenomenon, and it's replicated, in many, many, many examples. It's almost a separate phenomenon to how the Jewish community, particularly in the last, I'd say, 20 or 30 years, has really tried to provide opportunities for survivors to tell their stories, for the whole notion of intergenerational trauma to become part of people's understanding about what is carried and passed on from generation to generation. I think there's been a lot of educational work done around this topic, but it may still not impact individual families who are carrying it as an issue within their own family. But I mean, I'm often a critic of Jewish communal responses, but I think on Holocaust education, they're doing a pretty good job. Although I do think the last thing I want to say, which has come to mind, is I do get alerted in conversations like this to language about the Jewish community. See, I don't think there is a Jewish community. There are many different Jewish communities which overlap. And although we like to have the fantasy that we're all part of one community, the community is riven in all sorts of ways, politically and emotionally, psychologically, very, very different worldviews within the Jewish community. So although we use the phrase the Jewish community as a kind of shorthand, I think we just need to be aware of that that masks dividedness, difference, complexity, and the inability actually of Jews ever to really agree on anything.
Right. Well, the Talmud says that we argue for the sake of heaven, right? So on the one hand, on the other hand, that disagreement is really important and creative. I'm going to bring in, on the other hand, from the rabbi to the secular Jew. Susie, do you want to take
Yeah, I didn't mean to idealize our community. I think I really didn't, because I mean, my family was just repressed. That's why I said the whole thing about nobody who's in the mental health field doesn't come from difficulty. But there was a notion of community, which was very important for somebody growing up and trying to remake the world in the wake of the Vietnam War, the Civil Rights Movement, and women's liberation. Okay, so, and the idea of what we were meant to be doing that was really different. And I guess I still have that passion. Nuts as it is, I still have that passion. And I see it in some young people who do live online. They don't go online. That's where they live for a very large experience, a part of their experience. And I see that there's all sorts of interesting things going on for them, but I also have a whole set of fears around that. I mean, I'm totally agree with you, Howard. The neoliberal agenda, which was brought in by none other than Tony Blair, has been a disaster for health and for education. It's absolutely disastrous. And the only time I like targets is on the first 1,000 days. I mean, I'm with Louise there. I think, the most important effort, and I've written papers for the government, and I've tried to get programs off the ground for precisely so you get two populations in one. You get the parents, but usually the mum, and you get the newborns. But it's very, very hard to do, but I think that is what we need to do. And we need to do it urgently, because we are in a lot of difficulties as a society. And it's not that difficult to do good interventions. You don't need to be a trained analyst or a trained psychiatrist. You do need to know something, and you need to have a really good support system, but you don't need to be trained for 10 or 12 years in order to actually listen and to engage and to help. And I agree again with Howard, that's been the sort of bringing the awareness of the Holocaust has been really important to the Jewish community and to Germans, frankly. I mean, it's, you know, there are very, very important initiatives that have gone on over the last 30 years. And we need a kind of initiative now that allows us to take risks with sharing how the hell we feel and what we need to do about it. So, Dave, I'm counting on you to take this in as the patient advocate into our health system, because you've obviously worked hard enough in there to get yourself in a position to do that. But I don't think it's just in the mental health system, which I think is in a very problematic state. It's also right throughout medicine.
Yeah.
Anyway, now, I guess the answer is now.
But I love that rallying call. And, you know, we've been talking about the political, and, you know, I grew up too with the personal is the political, but maybe it's also the political is the personal.
Absolutely, it always went both ways.
Yeah. Fantastic. So it's really interesting. Our questions are beginning to come in, although please, we'd love some more. And I was looking which one to pick. And actually, it's a question on a completely different topic. But funny enough, it comes from one of the top Holocaust educators in this country. So seeing as that's what we've been taught, what we've been talking about, I'd love to bring Angela Gluck in, who has written many, many books on Holocaust education, but actually has and might want to talk about that as well as the real question she wanted to bring to you all. You need to unmute, Angela.
Yeah, I too, Howard, you know, you think I'd have learned something. Okay, so thank you, but no flattery. So my question is really very, very basic, and it's something that's that I live with all the time. So the question really is, and it's not meant to be cute, is what actually is the mind? Because we talk about the mind, and earlier on it was mind and body, and I'm thinking, if there is a physical component in the psychological element, what is that, and where does one end and the other begin? So it's really quite basic and not specifically to do with Holocaust memory, but what do you mean by mind? And if it is affected by body and affects body, what is the connection? And if you can do that in 3 words, it would be great.
Okay, so I'm going to start with Susie, who happens to have a book called Bodies, among many other things. I don't know if you'd like to.
I don't know if I can answer that, because I think it's too big a question. I think what we used to understand, and this is where Freud's came from, was that trouble in the mind would affect the body. That was his great advance. Yeah. I now think that trouble in the body is now deconstructing mind. When I see what's happened with performance culture and celebrity culture and the production of self, I see very, very disturbing aspects of, but I think you're asking a very different question. I think the best person to answer this is Mark Soames, who is not with us, who has written a fantastic book on the wellspring of consciousness. And it's much more sophisticated than any of the sort of stuff that is sold as being interesting on bodies and mind. And I think one of the things that he would talk about, and I would talk about myself as a clinician, is feelings, affects. Mm-hmm. Feelings are the most profound, like language, unity of the production of mind and body. Because a feeling is both profoundly physical and cognitive, isn't it?
Yep. Thank you.
And so just like speech production is profoundly physical, whether it's done through hands or through lips, as well as resonates onto the other person or fails to. So it's not what you're asking, and really you need a whole seminar on this, but it's just a little taster of how I think about these things.
It was just quite simply that, in the last hour, there's been body and mind, body and mind. I think, well, what is this exactly? What are we talking about? Anyway, thank you, Susie.
I've just done it now. Maybe I'll also just ask Louise, do you have a comment on that? Because as a psychiatrist, your treatment is often not just talking therapist, but medication, which does act on the body. So I don't know if you have any thoughts about that.
I think when Angela was asking the question and asking for 3 words, my 3 words would be it's very complicated, which is I guess what Susie was saying. You can think about the brain and the functions of the brain, but the brain has multiple functions that are not to do with the mind. So that, the brain obviously controls movement and breathing and, things which are nothing to do with the mind. So there's an argument about whether the mind is even located within the brain or entirely separate. We know that we can look at some functions of the mind, some elements of the mind in terms of bits of the brain and how they work. And, if the brain's not working at all, that the mind can't be communicated, can't be seen. I guess there's a spectrum with spirituality as well, that sort of some people may equate the mind and the soul in a religious perspective, and others may disagree. When we're using medications to treat, I guess we're treating the brain really, and then the impact that treating the brain with medications has on the mind is what we're aiming for. But really tricky. I wanted to just pick up on what Susie was saying there as well, thinking about emotions and affect, and I think that brings us back to community, because if we think about the fundamental purpose of emotions, we can think about why we have legs and why we can move so that we can run away from lions and keep ourselves safe and look for food, and we can think about the purpose and the function of other bits of our body, but what's the point of us feeling things? Where does that come? Why do we have that? Why have we evolved to have such strong thoughts and feelings? And I guess it's about communicating and linking and relating to others. That is, and again, there'll be other responses to that, but one of the purposes of feeling things is so that we can check in with other people and see how other people respond to us. And so I think that concept of the mind can link us right into interpersonal relationships and the need for community.
Brilliant, thank you. And David wants to come in on that.
I want to comment just on a very practical element of that and bring it down also to the concept of recovery, which Howard wanted to allude to, is from the insider's point of view, having, quote, recovered, a very contested term in mental health politics, by the way, that my recovery, and it's a point about the system, was I was beginning to do better, but not feel better. So I was discharged at the point when I could read 2 pages of a book, when I was beginning to eat properly, and I was discharged. But I was feeling like shite. And so I had the physical energy to go out and do stuff, but my mind was telling me, well, if I'm going to feel like this, I might as well jump on the tracks, because if this, so there was a disconnect between my cognitions and my behavior, and I became a Skinnerian, a behaviorist in hindsight, that actually feelings lag, but no, feelings and thought lag behind behavior. So I had to continue to act as if in some form of really vulnerable trust that it would all come back to me. And at that point, I was discharged. And it was the most vulnerable time. And I don't know whether there's any data, Louise, on the amount of suicides that take place post-discharge of secondary care. But at that time, it was a really dangerous time. So I just wanted to put that in to try and cement us back into what's needed for people in the community.
Thank you.
Thank you. Thank you.
Do you want me to just respond about?
Oh yeah, please.
I can't give you exact data, but post-discharge, immediately post-discharge, is one of the highest risk times for individuals. And again, it might be contested, but I don't work in an inpatient setting anymore. I did as a trainee. There's a concept of positive risk taking that, at some point you've got to give someone a chance to kind of function outside of a hospital. But I think David, sort of linking back to what you were saying, I think when you first spoke, that concept of safety is not good enough. So if we base everything just on risk and safety, we're exactly, as you say, sort of, hitting the target, but missing the point. So I don't have exact data, but yes, it's a high risk time.
Fabulous, thank you. And we actually do have a question about suicide that I'm going to come to in a minute. But before we do that, I just want to bring up what David said about behaviour and feeling not always acting in concert. Just to respond to this as a poet, there's a Polish poet, Maria Jarzemska, who's written a poem based on a very famous Polish saying, which is the soul travels on horseback. So it's about the fact that we can embody travel by aeroplane or ship or train or whatever, but because the soul's on horseback, it will always get there later than us. It will always take a different route and be slower in arrival. You were talking about behaviour and feelings. I just wonder, Howard, if you wanted to, maybe I'm going into kind of spirituality, and I don't know what that realm, but it just occurred to me to think about that connection between not just the body and mind, but body, mind and soul, and whether you had thoughts on that.
Well, I could probably conjure up some thoughts on it. It's not actually where my mind is going. I'm still hooked on this question about the mind and what is it. And I thought that what Susie said was very powerful about the interrelationship. She put it much more eloquently than I can do. But I do see some basic guidelines that I go by in relation to this question about mind. We know that mind is not the same as brain. I mean, Oliver Sacks used to talk about the 3 pounds of jelly up here, which is the brain, and that extraordinary, complex and always mysterious stuff which creates consciousness. And the philosophers talk about the hard problem is, what is consciousness? What's its relationship to mind? What's its relationship to brain? But in the consulting room, if I can put it into that context, I'm always, in a way, in awe, if you want to talk about the spiritual, I'm always in awe at the body's capacity to signal what's going on in another part of ourselves. And I'm using a generalized phrase, in another part of ourselves, to cover mind, the unconscious, a part of ourselves in which the body is only a kind of signaling system to other stuff going on. And I'm sure anybody who works in the consulting room in a kind of analytically oriented way will recognize the way in which symptoms occur and are reported, happen in sessions, and they're all, the body is a continual signaling system to other stuff going on. And I think about that other stuff going on as connected with this word mind and consciousness.
Fascinating. Well, what I'm going to do is take us from the spiritual, the concept of consciousness, to something that is deeply real, political and pragmatic, because David raised questions around suicide rates. David Lawrence, a member of our audience, has a very specific question about that.
Thank you. I was doing a strategy for suicide prevention with the London Borough of Hounslow and found that the data showed that suicide rates for London boroughs were going down until about 2012 to 2014 and then were possibly rising after that. Any ideas why?
Okay. Well, who would like to take that? Any volunteers?
Can we just hear the dates again, David?
Yes, the data should seem to show that until about 2012 to 2014 in different London boroughs, rates of suicide were going down, and then around that time they began not to continue to fall and sometimes to go up.
Louise?
I'm going to give two answers, I think, to that. The first one is slightly more, I guess, a slightly different way of looking at things, but there's quite a bit of evidence from around the world that having big community events, of which 2012 and the London Olympics was one, can actually result in a reduction in suicide rates. And so that there may be, you know, just as a sort of an aside and a point of interest, you know, I don't think that's the whole thing, but there may have been something actually around London in 2012 and kind of people coming together. The flip side of that is that there's also a very pessimistic view that, you know, there's an investment in clearing the streets and making cities look good superficially, so that there's a sort of a delay in suicides rather than actually a real reduction. But I guess just as a point of interest, that's one thing to think about. From my perspective, I think it's just it may, and I guess we never fully know the answers to these things, but it may well be just that reflection of cumulative cuts to various bits of social provision. And I say that across the spectrum. It's not just in terms of healthcare, but, you know, from youth workers to community clubs to, you know, just that ongoing decimation. And that's where I think the Jewish community has resisted that to a large extent, although obviously the Jewish community has felt the economic impact. I think that we're as a community able to buffer that to some extent. And to me, that's where the value of having Jewish communal organizations can come in.
That's really, really helpful. And can I put in a subsidiary question about this, which did I read recently? This is connected with the point about after large events. Did I read recently that the rate of suicides in the first year of COVID in this country showed a really remarked decrease? Mm-hmm. And if that was the case, and Susie's nodding, what would that mean? How would we understand and think about that?
I would see that largely as a lack of opportunity rather than a lack of a change in mental state. So I don't think it represents a real shift in people's distress or you know, emotions. Or I think I would see that largely as, you know, and we saw that with young people as well, but that young people weren't out and about. They didn't have access to substances in the same way, that they weren't able to kind of to plan and act on those impulses in quite the same way. So personally, and again, others may differ, I would see that as a practical thing more than an emotional thing.
Yeah, I wonder myself whether it was both. I mean, I think the fact that until Barnard Castle, whether there, even though it wasn't articulated, we actually did have a sense. This was before anti-vaxxers. Let's forget the side of culture. There was a sense that we were in something together. And that has been very rare, and it's been smashed over the last 9 months. But there was a very, very special moment, I think. You know, we had blue skies. It didn't mean if you were depressed, it was any better. But everybody was kind of in shtuck, I think is really the way I would put it. And I think there is something about that that was important, and it was being acknowledged.
Does that connect with a similar phenomenon? Again, I think that I read about in the first few years of the Second World War, that the suicide rate in this country dropped. Can anyone, I don't know if anyone in the audience can confirm that. That would chime with the notion of something, if there's some bigger project that people feel connected to, then something happens to people's individual sense of well-being and wish to survive. I don't know.
David,
I think.
Sorry,
I think there's. Oh, sorry, David, you go first. Apologies.
I just want to provide a nuance on that. And I'm not saying it was a majority, but it seems my role. Well, no, I won't say that. The slight difference I have is that a lot of people I know who had pre-existing mental health problems, to some degree, felt better. Not because of any communal project, but because of the lack of stimulus and social obligation and envy of others, because other people were in the same boat. Not it was a communal project, but none of us can get out, so we're all equal. And I'm not saying that was the majority, but there is just a slight, significant minority, I guess, who actually felt better. And I know who came off their meds, primarily those with anxiety. Particular forms of anxiety, and I don't want to generalize about that.
And I just wanted to come back, Howard, to your point about in the war. There absolutely was a reduction in suicide rates in the war, and there's two main kind of theories around that. One is, as you say, that sort of sense of community, and everyone came together and there was a joint sense of purpose. The other is that the population that were most likely statistically to have killed themselves, which is sort of younger men, were fighting, and a lot of people may have ended their lives by suicide in battle, but that wouldn't have been registered in any way as a suicide. It would have been a death in battle or in war. So this is where statistics can be quite deceptive, I think.
Thank you, everyone. I want to take us out of kind of reading into the lives and the thoughts of people who ultimately we don't really know and we can't speak for, but let's talk about it in a more positive way and about going forward and prevention. So on that note, Rebecca has got a question, Rebecca Taylor. I'm going to ask for a kind of quick fire answer to this one. Rebecca.
Hello, hi there everyone. Yes, speaking as the mum of a teenager, I'm interested in your thoughts on social media and young people and the good and the bad that effect is having. And can you just give some practical advice to a mum and other parents out there about the best way of dealing with this?
Okay, who'd like to take that? I mean, I know Louise is an obvious one, but I wonder if Susie as well has any thoughts.
I'm really too old at this point to say very much, except that, you know, I really like the kids who are standing up and saying no likes necessary, and who are daring not to perform and daring not to create these multiple identities where they're actually one person in their room and they're, you know, and another person on the screen. But really, I just despair. I particularly despair around the porn for 9, 10 and 11-year-olds. I mean, you know, and the body stuff. It's like the assault on the body is so profound that I'm in despair. So I'm going to shut up and please let Louise talk about this.
I think, you know, this could be the topic of a whole talk. it's too simplistic to sort of be good or bad. The reality is, there's nothing that any of us can do to sort of turn back time. We're left with it. For a lot of young people, it provides a source of comfort. It's very fundamental to young people's identity. The complexity of that is then the fragility of that identity. And as Susie sort of suggested, that the number of likes to a photo can have a profound impact on young people's moods, young people's sense of self-worth, and how they view themselves in terms of their appearance, their body, etc. So that there's a huge it all becomes very intertwined. The main thing that I would say in terms of social media use would be two things actually. Firstly, we know that mobile phones have a massive impact on sleep, and we know that sleep is hugely important for everyone, but particularly for young people. That sleep is very restorative. Young people are growing, developing. The brain continues to develop through into your mid-20s, and obviously beyond. We're all capable of change even after that. But the biggest sense of development. I would try and keep phones away from young people's beds if you can. So having a kind of, you can have your phone up until and whatever time you make that, but not allowing young people to have a phone by their bedside. That's really tricky because as adults, probably a huge number of us, if not all of us, keep our mobile phones on our bedside tables. So it's very difficult for parents to say, you've got to do that, but I'm not going to. I would advise it for all of us, actually. It's not healthy having your mobile phone there and having access to the entire world and to everyone else's opinions of us 24/7. So putting the phone away overnight. And the other thing, again, it's simplistic, but keeping that open dialogue. You want to be able to know if your young person has seen something that worries them. You want to be able to know if one of their friends has said something. You want them to come to you. So you need to be able to not be shocked, to keep a kind of open mind, to ask neutral questions, to be curious, but to show that you're coming from a position of caring. So it needs to be, I am the parent and I'm going to take a parental role on this, but I need you to come to me. I need to be your buffer for this. As I say, there's a lot more I could say, but I'll leave it there.
So I'm going to give one last comment on this to David, and then we're going to bring Rabbi Sybil in for the final question. David.
I totally get where Susie and Louise are coming from, and couldn't agree more about the porn side of things. It's terribly disturbing. But Louise, thank you for that, the dialogue thing. I was just reminded of the film The Kids Are All Right. Let's trust them a bit. The online digital stuff has certainly saved my kids during COVID and has allowed them to keep in touch with their mates. And it's allowed one of them to get CBT on an app when the iApp services are completely damaged and they can't get access for 12, 14 weeks. So I just think it's that nuanced view that we need. It's not all bad. And as I become a sad old git, I've got to remember to trust in the fragile strength of the kids coming through. And I think that stuff about open dialogue and trust brings us right back, doesn't it, to community and relationships and keeping those conversations going. So thanks, Louise, for that, because that really helped buffer what I was thinking.
And just to say, for all the complications and difficulties with social media and technology, it has brought us all together having this conversation now. And I know for many people, it's been a lifesaver during the pandemic, but also has opened up accessibility for people who otherwise felt very cut off from the world. So everything is complicated and nuanced, right? I'm going to say for myself how much I've really enjoyed having this conversation with all of you, and thank you for your thoughtfulness. But to ask the final question and then do a proper thank you, we're bringing in Rabbi Sybil Sheridan. So I'm going to pass over to her.
Well, thank you very much. Yes, you've spoken a lot about the value of community, and in some senses the Jewish community has been a great example in some ways for this. But I'd like to be a little bit more specific to ask you actually about the effect of religious belief on mental health, and whether there is an effect, and if that effect is positive or negative. I'm very aware that we have, a religious practitioner, a rabbi on the panel, as well as, an avowed secularist. And I'd be interested to know whether your answers are the same or are different because of where you're coming from.
Shall we start with the rabbi, Howard?
I think we know that religion at its best can aid people's sense of well-being, purpose and meaning in life. Being part of a community, that's different actually from religious belief, by the way. You can be part of a community with a kind of all sorts of different beliefs. But being part of a faith community can be, a source of strength. We also know that religion can drive you mad, and that, as one of my mentors says, belief is a form of cruelty. And too hardy a gluing of oneself to beliefs can make people cruel and mad. So I think that the answer is complex. I think that's probably all I want to say at the moment.
David?
I'm particularly struggling with this as I've married out and have 2 children. We are the end of the line, and my great-great-great-grandfather was Rabbi Samson Raphael Hirsch. So if anyone knows their lineage, he'd be turning in his grave. And I'm struggling with it. And I struggle with my feelings about Zionism and Israel, which we haven't talked about. I'm really struggling with it. The only thing I think I've become in the last few weeks a Jewish agnostic Buddhist, if that makes any sense at all. And as a storyteller and poet, of course, our story, the cultural story and the narrative and words are deeply important. So that's probably what I most am valuing at the moment, is that our culture is about words, story, narrative. I'm clinging to the wreckage. Not wreckage. No, that's the wrong form of words.
These fragments I shall store against my ruins, maybe. Louise?
I think it's both. And I've seen religious belief be the content of a lot of psychotic illness amongst the adult population, including, I actually had to section someone as Jesus of Nazareth because that was the name that they gave. So that was the name that was on the section papers. And I think religious belief can cause a huge amount of distress if it tips into that being unwell. But I've also seen the huge positives and the sense of hope that religious belief can bring for some people, that things can be different, will be different, and that there's a timeline to it. So I guess the good and the bad.
Thank you. And last word, Susie.
I suppose I think about meaning rather than religiosity. Just because I'm secular, it doesn't mean that I'm not interested in meaning and connection and survival and truths. And I think that all of those things are quite spiritual, really. You know, but we have our connecting spiritual experiences in different ways if we're secular than in an organized form. So I don't consider my secularity to be non-profound or non-spiritual at all. I think it has a lot in common with people who are very moved and engaged with religious practices.
Thank you. And if it's a search for connection and a search for meaning, I mean, that's what this evening has been about, really, hasn't it? So maybe that's part of all of our Jewish search for belief. I'm going to pass over to Sybil, though, to take this forward.
No, it reminds me of a definition I heard only recently of Judaism as the belief in one God or fewer, which I think includes us all. I do want to say, Louise, David, Howard, Susie, what an incredible evening this has been. If we talk about profundity, the wisdom that you have given us with your insights, for very different people with very different skills in the field, coming together with very different answers and yet creating between you a whole. And I felt a tremendous sense of healing in the words that you gave. It has been, for me, a very wonderful evening, and I really do want to thank you all very much on behalf of all of us. We can see many people are indeed applauding at this point. We're moving towards the end of our series now, the last of these on Jewish medical ethics next week, where we look at the end of life and assisted dying. So I think on that cheerful note, I shall wish you good night and look forward to seeing you all next week. Bye.
Thank you. If people want to unmute and have a sounded appreciation for our panelists, we'd really appreciate it. Thank you very much.